Hi everyone. Thank you so much for organizing this, and thank you MC and Dominic and Ben for warming us up. And we are now entering into our second debate. I will read to you the motion, and then after that introduce to you the speakers. Motion 2 is entitled Clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. Clinicians should focus on translating the best science and technology to clinical practice. Clinicians, right? And not be burdened by health economic considerations. Now, as a trainee and growing up in an environment that has seen a lot of change with a rapid uptake in all sorts of technology-assisted innovations, we have seen what we can call seismic shifts of opinions, ranging from a almost nihilistic type of approach to treating any patient with metastatic disease, all the way to the other extreme, whereby almost experimental treatments are given as a last-ditch effort to save them. So now, obviously, this doesn't directly translate to proton therapy, but it centers on issues discussed in this motion. And so I think the idea is for us to dig in and back to our own experiences and listen to the speakers and see which side resonates with us. A quick introduction to our proposition speaker, Dr. Chua Yu Tiong. He's no stranger to us. He is a mentor to many of us here and has held headships and presidentships in societies and so on. But at the heart of it, he is a passionate clinician, and he will be sharing with us his views as the proposition. And I'll introduce our opposition speaker later on. So Dr. Chua, please.
Good evening. The moment God gave us the concept of free choice, we have placed a value proposition upon the act of choosing one or the other. It may not be monetary value, but other values such as ethical, moral, pleasurable, or even collective societal values. So the first premise is we cannot divorce ourselves from value while we choose to accept or to provide treatment. The topic is clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. If you look at the highlighted parts of the debate motion, you will see several issues. The first is focus. It means the clinician's job is to put his main effort in his work, and that is translating the best science and technology to clinical practice. He cannot avoid the judgment completely, but the focus is definite. The second is the word best. It means best in its scientific merits without the cost element. Finally, the term burden can mean different things to different people. It would imply that there's some, but not burdensome, health economic considerations. The presentation is divided into two parts. The first focuses on how the clinicians are involved with translating the best science and technology. The second part of the presentation is to reveal the pitfalls of health economics, and there are compelling reasons why clinicians should avoid getting involved. Let us start with the first. When clinicians translate the best science and technology, they're delivering this through the whole entire gamut of clinical management of the patients equipped to deliver the best treatment. Think about the ethics involved. Continue to gather accurate data, educate others and oneself. We are down right at the bedside. Let us take a quick look. 1. Concentrate on developing and delivering better treatment resulting in better survival and, of course, less side effects. 2. Assess the ethical implications of not offering and over-prescribing the best treatment. Leave it to the health economists to deal with it. In real life, the clinicians have to bear the brunt of this issue. They have to explain why a particular treatment cannot be given because of costs. Much time has been and will be spent in the clinics explaining, a job the clinicians have to manage, having already cultivated the doctor-patient relationship. If only this can be left to the authorities of health economists to tackle. The ethics of overprescribing and overselling is another area. 3. Clinicians should look into educating colleagues in other medical fields, administrators, and the public on these treatments. Fake news is a flavor of the moment. Educating the public comes in several ways. Besides accurate information of the use of the treatment modalities, there is the issue of perception. The more expensive the treatment, the better it should be. A very real perception fallacy that needs to be addressed. Expectations should also be managed through education. 4. Do good work and collect data. Here, the authorities must see the value in providing enough personnel to accurately collect the data, both for healthcare allocation as well as to have accurate input for analysis in health economic models. Survival and side effects data require long-term and sustained funding, sometimes into several decades. 5. Be prepared for the future of personalized treatment, such as genomic profiling and selection of patients that will benefit. Even explore studies like barcoding of cells as a means to identify specific cell groups to target. Now we look at the pitfalls in health economics and health economic models. Let me just give you a real-life example. In the early days, as far back as 2006, we had to write papers to present to the authorities controlling the purse strings for setting up the Proton Center in Singapore. As the economics of setting up the center depended on many factors, in writing the paper, we had many assumptions on data collected to create a situation in our favor, and of course, that similar data could be used by the opposing camp to deter setting up the center. A yes minister situation arose. Depending on whether you want it or you do not want it, the data can be used in different ways. First, patient numbers. The more patients that are treated, the lower the cost per patient. So we included all private patients that are liable to be treated in Singapore, summing up the numbers from both the public and private centers. Whether this will really happen, we do not know. We made that proposal on the assumption the science was so good that no one will be treated by any other means. Then one cannot divorce the cost of setting up the center in computing the cost per treatment. This is especially so in land-scarce Singapore. In fact, the authorities proposed setting up the center in a far corner of Singapore rather than in the vicinity of the Pinnacle at Duxton Plain, which is near the Singapore General Hospital. The Pinnacle was probably the most expensive public housing then. Of course, we were horrified by the proposal. Sure, the cost will come down substantially, but it will be setting it in the midst of some secondary jungle away from any medical activities and facilities. On a more serious note, specific disease health economic models are fraught with problems. Are economic models adequately addressing questions relevant to oncology decision makers? If the data used is inadequate to represent the disease states or the patients, for example, they may be from clinical trials alone with specific entry criteria. Are the economic modeling making too many generalizations to fit the models? What are the guidelines available so that they can even be comparable between users or countries? What is quality adjusted life year? When the quality of life data collected is not individualized and changing even as you treat. Finally, has the modeling kept pace with treatment innovations, or that the individualized treatment is becoming the norm? These are just some of the issues health economists grapple with. So clinicians leave this out of the busy schedule and concentrate on delivering the best treatment. Hence, the term health economics in the proton-photon debate is perhaps misplaced. The topic should be more crudely but honestly stated as: should clinicians implicitly will dispense the best treatment, worry about patient paying the bill, and hospital recovering the fixed costs when it comes to choose proton versus photon therapy? Conclusion. When I was asked to propose the topic, the organizers must have thought I was a socialist and would ignore costs. Truly, I'm more a capitalistic socialist, or more correctly, a socialistic capitalist. To be truly socialist, I would be in an utopian society where costs play no part. Nevertheless, even if costs do matter, clinicians must not be burdened by cost considerations while they devote their minds and energy to producing the best for patients. By doing so, their efforts and undertakings will improve lives and even, well, reduce costs in the long term. Thank you.
Thank you, Dr. Chua, for so much information compressed into 6 minutes. The next speaker is Dr. Matthew Callister, a new old friend over the past few years, who is a seasoned clinician. He trained in Mayo and then went on to serve in Banner MD Anderson's new setup and built it up. And then, like many esteemed colleagues in Singapore, moved on to administration, becoming the medical director of Banner MD Anderson Cancer Center, and subsequently senior physician executive. And over the past few years, he has moved his family to China and is now Chief Medical Officer of Concord Medical Services, being in charge of their proton therapy project as well as their 3 cancer hospitals. So he will share with us his experience and views as the opposition from the perspective of a clinician with administrative experience. Dr. Callister, please.
Dear colleagues, good evening. I so appreciate this invitation to participate in the annual Singapore Radiation Oncology Dinner Symposium. I truly regret that I can't join with you live at the events or be in person due to international travel over the holidays, but I do look forward to watching this event in the coming days by recording. First, let me acknowledge to you that I do feel that clinicians have the central role of judging the advancement of new science and technology and its application into clinical practice, and truly believe that clinicians are the only ones that are really able to capably judge the importance and value of these new emerging techniques. But at the same time, I believe that economic considerations are well within the scope of physician decision-making and should not be completely relinquished to others. I suppose there are good reasons that clinicians should remain engaged in issues regarding costs from many different perspectives. We should have a voice in the distribution of society's limited resources and in our efforts to promote health equity for all. We should certainly be involved in what is an emerging toxicity of financial toxicity for patients and looking for solutions. But there's 2 issues tonight I'd like to mainly emphasize with you. First of all, that as clinicians, frequently we do not know enough to advance new technology and treatment based on scientific evidence of efficacy alone. What do I mean by this? In an ideal world, the clinical implementation of new technology and treatment will be solely based on complete high-level evidence from prospective randomized clinical trials that are reproducible and can be broadly applied to all relevant patients. In reality, however, we know that as individual practicing physicians and as institutions and societies, that often we have to admit that the level of high-level evidence that we want is not sufficiently there to judge new technologies or emerging treatments. Prospective randomized trials are often inconclusive or have not taken place. Retrospective studies often suffer from bias, reproducibility, or have conflicting results. In our individual clinical practices, we're constantly having to struggle with patients who have diagnostic or staging uncertainty and may very well not have been included within the inclusion or exclusion criteria of studies. We see patients with rare and uncommon diseases that have been understudied. So what I'm trying to say is that in the absence of pure evidence from the scientific method regarding efficacy, we naturally have to apply imperfect judgment from a variety of perspectives and sources that includes financial issues as well. In this setting, we need to broadly include efficacy, safety, quality of evidence, consistency, and economic considerations. Secondly, I would propose to you as clinicians that if we do not engage successfully in cost-effective considerations, others will do this for us. The reality is that resources for healthcare are fixed, and to some degree, obtaining them is competitive. Decisions and judgments will be made, and so we need to stay engaged in this topic, particularly at institutional and society levels. I'll point out as a solution or a direction that I think is encouraging to us that we should follow as radiation oncologists. The NCCN publishes not only practice guidelines, but practice guidelines that include evidence blocks for most of its diseases. These evidence blocks are a 5-point scale that cover 5 dimensions, not just efficacy, but also safety and toxicity, quality of evidence, consistency of evidence, and financial affordability for each drug treatment regimen. A similar system for radiation oncology I'm not aware of, but I think it would be very helpful as we continue to engage in emerging techniques and technologies, which certainly often are expensive. Moving forward, I favor that as clinicians, we continue to strongly engage in cost-effectiveness considerations, so that we can have a voice in determining and calculating this imperfect but critical equation of value. Who does this? How do they do it? I suppose in our goal to support the individual practicing physician and the patients they serve, we need to continue to align and define our judgments at institution and society levels. Thank you again for your time, and I look forward to hearing more about this important topic.
Thank you very much, Dr. Callister. Again, packed with many nuggets of truth, and you may have started off citing one side of the motion. Now I think you might be a little torn. So let's move on to the rebuttal, starting off with Dr. Chua and his 2-minute rebuttal to Dr. Callister's speech. Dr. Chua, please.
It is certainly an insightful presentation by Dr. Callister, who rightly pointed out that clinicians should literally not cut themselves off from financial considerations in delivering treatment. They should have a say, and they are the best people to do so. However, the organizers of the debate have left me with a way out of this situation by using the terms focus and burden. Both of these terms imply a certain amount of leeway from the extreme. While it is true clinicians should be the best people to prescribe or recommend treatments, bearing in mind the limited resources, the issue is one of extent of involvement without being burdened by such considerations. When a clinician is bogged down or burdened by financial considerations in medical treatment, he loses focus in his primary mission, which is to deliver the best science to his patients. Many clinicians are involved directly or indirectly in the collection of meaningful clinical data, in examining the ethics of treatment, whether in giving or withholding, acting as patient advocates and collaborating with others and in educating themselves. The science of health economics gets very complicated with mathematical modeling. You really do not want a clinician to be embroiled in health economics. Instead, we should leave a certain amount of mystery and ambiguity to this branch of economics. A medical specialist with deep involvement in health economics on the other side of the fence, the administrative side, may end up being a hindrance. As it is well noted, where you stand depends on where you sit. So just continue with the science. Your involvement in health economics will come indirectly. Thank you and Merry Christmas.
Thank you. Merry Christmas, Dr. Chua. Still torn? Well, let's hear from Dr. Callister and his reply. Dr. Callister, please.
First of all, let me congratulate Dr. Chua for making such a persuasive argument in support of the proposal. I agree with the core principles he articulated and certainly would advocate that as clinicians, our primary focus should be to concentrate on providing the best possible care for our patients. But in closing, let me emphasize 2 final points. First of all, value is not just a variable, it is an equation that is based on multiple factors that can be dependent or independent of one another, an equation that can be quantitative or can be calculated even qualitative, I suppose, imperfectly. So my point is that if we choose just to consider efficacy the best possible treatment, we're actually not calculating value since it's an independent factor. I think we need to be engaged in all possible factors related to value, which certainly includes cost. It's not something that we can give to the economists, the administrators, and the policymakers to calculate on their own. Secondly, when we deliver medical care, we do so on the historic foundation of knowledge that has come forth through the scientific method. But that foundation has already been highly influenced by issues regarding cost and many value calculations along the way. Basic and translational research, which has been competitively funded by the public sector, involves a value equation of not just great ideas, but financial budgets that are feasible to make the proposed projects move forward. In the private sector, R&D investment is based on a value equation not only of clinical impact, but also favorable recovery of costs. Even the clinical trials that define our standard of care are based on determinations of scale and scope by economic considerations of which trials are possible or to do based on finances. So please understand that I think that best possible care is the most important emphasis as physicians, but that we can't excuse ourselves from the calculation of value, which includes cost and economic considerations. Thanks again.
Thank you very much, Dr. Callister. I do wish that he could be here with us. He's probably transiting in some international airport now, heading back to the States from Guangzhou. But we have Dr. Chua online. And I think before we open up to questions from the floor or comments, perhaps Dr. Chua, you may want to have say a few words about your response, as well as how you feel the debate has opened up issues on both sides. So first, as the proposition, and then after that, as a fair-minded individual.
Yeah, I guess the very fact that I'm the proposition means that I have to support the motion. As I said, where you stand is where you sit. So at this juncture, I'm sitting on the proposition side. So that's how I have to go to debate and prove my point. But the fact of the matter is I totally agree with Callister that, you know, we have to be involved. But I think the ultimate question in everybody's mind is who is going to pay for the treatment? I think that will depend on many other factors, like, for example, the larger the economic pie a country has, the more likely you're going to be able to provide more expensive treatment to people. We're talking about the GDP of the country. So the larger the pie, the more likely. So in Singapore, we're only spending 6%. You know, the States, it's 17%. The question is, if we move to that sort of level in our GDP, will we be able to provide more of this expensive stuff? The second thing is, of course, government foresight and legislature. That means they are really preparing to increase the costs in healthcare spending as well. So you have all your Medisave, Medishield, in America, Medicaid, to provide for the financing. The third is, of course, taxation for provision of infrastructure. And you can put it the other way around, cut the doctor's pay or something so that you can have more money to buy more of this expensive stuff. And finally, of course, you have still insurance to come in and charity. So all these is going to provide the payment for your treatment. So that is what we're actually asking ultimately. Of course, healthcare economics will help to, at best, justify or distribute resources to its best places. But at worst, it just gives us an awareness.
Thank you, Dr. Chua. I suppose you started off from the perspective of the proposition, and then along the way, you morphed into a fair-minded individual, summarizing both ends of the spectrum.
Yep.
Correct?
Yep.
Now, maybe at the same time, You guys can keep your questions coming. I will refer to the chat soon. There's time, but not so much. So please put down your questions or comments over the next minute or so. Then we can talk for another 2 to 3 minutes before we move on. So if I may summarize, there was this book written by politicians, by a senior politician, S. Jayakumar. He called his book Be at the Table or Be on the Menu. So to a certain extent, Dr. Callister's point was that we as clinicians, if we want to join in the discussion, we need to be at the table. Otherwise, we will be on the menu. And I am so glad that radiation oncologists have stepped up over the past decade. And I think more of us, or less of us, are on the menu anymore. And hopefully more of us can sit at the table and communicate. But having said that, I think Dr. Callister made a conclusion which I'm not sure we were able to catch. But he said that institutions, governments, etc., should provide some guidance as to cost or value considerations. This is because I think the fair-minded approach in understanding the nuances as a whole is a very tall order that only mature and experienced clinicians will be able to have and to make the call. I can't imagine a newly minted attending or consultant struggling with communicating with patients and making treatment decisions, being confounded by yet another consideration. And the final point I want to make is about the holy or unholy trinity, the 3 Ps, you know, the patient, the payer, and the provider. Right now, we are talking as if there is only 2 parties in this trinity, being the patient and the provider, but there is the payer. And the payer may be sometimes the one creating a lot of confusion because the payer wants to look good, promises the sky, whether you are talking about the government or the insurer who are attempting to attract people to buy their insurance plans, giving a higher premium, say, for example, to say that they provide proton therapy coverage. And then on the other hand, it is the provider who has to stand on the payer's side to be the gatekeeper. So these things really confuse the matter, and I think the purpose of this debate was really to open these up. And I'm glad that both clinician, administrator, debaters shared the heart that clinicians should focus on translating the best science and technology in their clinical care first. Okay, so in terms of questions, Dr. Chu said, what would you write to insurance company to justify Proton? Jeffrey was asking who should fund a health economist. Yeah, good question. And Dr. David Tan says text the bankers more. And Dr. Bala said, did we have so much debate when we transitioned from 3D to IMRT? All are good questions. I guess we all do know the answers to this. And I hope that this debate has opened up the issue so that all of us can understand what are the underlying currents at play. Now, I'm going to introduce an interesting segment into this debate. It is the polling function that we have in Zoom. There are no answers and there's no ultimate right and wrong, right? But now the poll is an opportunity for us to vote which side of the motion we're on, and we'll get the instant result within 30 seconds to 1 minute. So feel free, go with your free spirit and your instinct, okay? Clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. Come, let's go. Are you proposition, opposition, or you're fair-minded? Don't think so much, just go. Hurry, 10 seconds, 20 seconds. Trust your instincts, go with your heart. Drink more cocktail. Okay, can we see the answers, please? Yeah, lah, Jeffrey Tuan, fair-minded means sit on, it's a nice way of talking about people who cannot make up their mind. Lah. Sit on the fence. Okay, wow. So we have 40% who oppose, which means that they believe that clinicians should participate in health economic considerations. And then I'm glad, it's amazing that everyone has taken a stand, or the majority have taken a stand, 74% have taken a stand. I'm not saying that the 26% haven't took a stand, but I suppose they understand both sides of the debate. That is great. Thank you very much. And this is information that is just going to be kept within here. Now, we didn't do the poll for the first motion. Maybe we should do it now, just for our own information as well. Proton therapy will be the new standard of radiation care in the future. Nobody says anything about a timeline here, 10 years, 20 years, a century, whatever. Go with your heart and your instinct. Come, let us know what you think. Oops, polling not start or end. You want to try again, controller? Can you bring up the poll? The debate, the poll for the first motion. Okay, it's up again. Let's try. Go with your heart and we'll see the answers. Can we flash out the answers, please? All right, it's interesting. So 52% of attendees here believe that proton therapy will be the new standard of radiation care in the future, without a timeline specific to this. And it's interesting, that's great. Let's all look forward to the day whereby the cost comes down and we can all, and the technology continues to improve, especially in image guidance and beam shaping, and we can all give the best treatment to our patients. Now, without further ado, I'll call a close to this debate. Thank you, Dr. Chua and Dr. Callister, for your wonderfully prepared speeches. I will now hand the time over to the MC.